All right, our last session for today is our Meet Our Team panel discussion. Our moderator will be Dr. Walter. Our panelists today are Dr. Fernandez and Dr. Lefevre, so you already know all of them. Two people you have not yet met today are Taylor Rush and Susan Light. So Dr. Rush received her PhD in clinical health psychology from East Carolina University. She completed her internship in health psychology at the University of Florida and a 2-year fellowship in health psychology at the Cleveland Clinic. She has been on staff at the Cleveland Clinic since 2015 and divides her time between working with patients with movement disorders, chronic pain, and headache on integrated care teams. Susan Light is an occupational therapist and graduate of OSU. She joined Edwin Shaw in 2002 and is a certified brain injury specialist. She is a great asset to our patients and is certified in BIG, Delay the Disease, and POWER. She started the Parkinson's exercise class at the Akron General Health and Wellness Center in Bath in 2017. So I will turn it over to Dr. Walter.
Great, thank you. So we got a lot of really great questions here from you guys. And we'll start with the first one. So this is for Taylor. How can I motivate myself when it's really hard to get going?
Okay, so this is a question that I often get from many of my patients who have Parkinson's, because often they do feel higher amounts of fatigue, they have lower energy, their sleep may not be as good, and so they often find that when they want to try to get things done for the day, keep a schedule, it can be really, really difficult. And so, some things that I often will give in terms of, thoughts and ways to kind of practice improving that is, one, try to stick to what I call the 5-minute rule. So if you think about a task that may take you 30 minutes to an hour and you're like, oh my gosh, just the idea of doing it makes me tired, think about what it would be like to try to do it for 5 minutes. And if you can go for 5 minutes, see how you feel after 5 minutes. If after 5 minutes you want to stop, then stop. But if after 5 minutes you're like, oh, it's not so bad, I'm breaking the ice, I'm feeling it a little bit more, then perhaps try to go for another 5. But really, we just want to reduce some of the expectation that you have to always complete everything in one fell swoop. And for many people, once they kind of get started with something, they start to feel a little bit better. So really, we just want to find some ways to sometimes trick the brain into realizing that it doesn't have to be this overwhelming experience. So try the 5-minute rule.
So this next question, I think we're going to tie in a little bit. So if you're having trouble motivating, sometimes sleep is an issue as well. So for Catherine, who's joining us remotely, what are your best recommendations for overcoming sleep deprivation related to Parkinson's disease?
Hi, yeah, thanks for having me again. That's a really good question. And as most of you know, sleep is a big issue for many people. I think it's really important to figure out where the sleep deprivation comes from, right? Is there unaddressed off symptoms during the night? Are the Parkinson's symptoms acting up? So does the medication need to be changed? Is there other sources of pain? Is it a bladder issue? Is it anxiety? So there's not really a one-size-fits-all answer, I would say. But with that being said, for people with chronic insomnia, after all of these issues are addressed, there's really good evidence for what's called CBTI, which is cognitive behavioral therapy. So kind of retraining your brain. And there's actually a lot of good resources. There's an app called CBTI Coach. Many things you can ask your health team about that actually can have a more long-term effect and often works better in the long term than pills.
Okay, thank you. For Susan Light, how is physical therapy different than occupational therapy with regards to treating for Parkinson's disease?
All right, so I work very closely with physical therapy, and one of the things is when people come in, they're like, well, why do I need OT? So with occupational therapy, one of the things that we can do is, like you heard earlier, we do work with vision. We do work with a lot of modifications. So we can go through and make modifications for home, like you saw in the lovely pictures. Maybe not as colorful as those pictures, but We can help with those modifications. But some of the other things that we do look at is like, can you cut your food? How's your handwriting? How's your coordination? Can you do your buttons? You know, there's a lot of those kinds of fine motor components that are often missed. And people are like, well, I can do it. It might take me 20 minutes, but I can do it. But the goal is not to have it take 20 minutes. The goal is for it to take like 3 minutes and to be done so you can go about your day and you have enough energy. So, you know, OT can work with all the balance and everything too, like physical therapy does, but we deal with those fine motor as well. And then I do routines for my clients. So, you know, I get you guys on a program and say, hey, keep moving as much as you can.
Thanks. And for Dr. Fernandez, here's a question about Kamobi. Somebody's reporting they have a patient in their family that does not have tremor but is confused and very slow going in the morning. So would Kamobi be useful for that? We're talking about somebody who's in their mid-80s with Parkinson's for 7 years. How would you approach that? What are the kind of the pros and cons there for starting Kamobi there?
Kinmobi. So Kinmobi is the brand name or the trade name for sublingual apomorphine, right? So sublingual apomorphine or Kinmobi it's one of our on-demand therapies. What does that mean? It's not meant to be your standard medication, but mainly as an on-demand or rescue therapy. So when you take, for example, your Sinemat or levodopa 4 times a day, say 8, 12, 4, and 8, and you know you took it at 8 a.m. and by 11 you're wearing off and you're slowing down, but you're not due until 12 noon. And when you take your 12 noon Sinemat, it still takes 30 to 45 minutes. So then you have a net gap of about 1 to 2 hours. So that's where the Kinmobi works. So it fills in the gaps that your standard dosing might not be able to do. So the good news about Kinmobi is that it works in pretty much 5 minutes, 10 minutes the most. The bad news is that it only lasts for an hour and a half the most. So it is really meant to fill in the gaps, not to be your standard therapy. So if you have Parkinson's disease, unfortunately the mimickers of Parkinson's don't respond well to Kinmobi. It has to be real Parkinson's disease, and the medication effect is not connecting from dose to dose, and you need immediate relief, Kinmobi or levodopa inhaler. Those are rescue or on-demand therapies that you can consider.
So here's a question that I'll answer. Somebody's asking, in their case, they have an Abbott DBS system, and they're asking, without having additional surgery, will they be able to update what they have? And essentially, I think this is somewhat true for all the DBS surgery devices. And then there's some caveats, too, where there may be some bigger upgrades. The technology is rapidly changing. Every 2 years or so, we have some new technology, and it comes in different ways. Some of it's software, and some of it is hardware in the battery or pulse generator, and some of it has to do with the lead design, the part that goes in the brain. And that last part isn't one that you really want to change, and that once you have the brain surgery and have that pacemaker wire placed, that's something that you don't want to upgrade or have to change. But software is very adaptable and is constantly changing, and that's something that they're constantly getting updates that we can update systems, and we see additional capabilities in these devices when they do update. So. Sometimes it's a regulatory issue. So like with some of the rechargeable batteries that are out there, the Medtronic RC, for example, initially had just a 9-year battery life. And when it became clear that the battery lasted longer than that, they extended it to 15 years, and they just reprogrammed the device and changed the parameters so that it would keep working for 15 years. And for these other devices, as they get additional capabilities, telemedicine, different programming parameters, they could update the software. And then the other thing is with the battery, and this does involve surgery, but the non-rechargeable batteries do need to be replaced every 3 to 5 years or so, and then the rechargeable batteries get replaced every 15 years. Well, that's a small procedure compared to the brain surgery. They just like changing a pacemaker battery. They make a little incision, take the battery out, and put a new one in. But whatever technology is around when that battery is replaced would typically be the technology that you get. And if many years have passed, it's likely going to be much more advanced. It may be smaller. It may last longer. It may have other programming capabilities. So that is something that some of this technology is something that would continuously upgrade in one way or another for Abbott and for the other systems. Okay, now we have a question. This is going to be, again, for Catherine Lefevre. This question is, when they tell us to avoid protein during medication ingestion, do they mean animal protein? Is vegetable protein less intrusive?
Yeah, so, and usually the issue of protein is it can interfere with the absorption of your medication, but especially carbidopa levodopa. And so generally you want to just not eat it ideally at the same time and leave like half an hour, have your medication half an hour before, an hour after you eat. And otherwise, it really is not necessarily different, eating dairy versus animal protein as far as the absorption goes, but biochemically it's not different. But it still depends. I mean, people have different food sensitivities. So, and I would generally say it's not a hard and fast rule, because ultimately, especially if you are at a stage in your disease where you take medication very frequently, and some people do, right? Sometimes you take medicines every 3 hours. It can become almost impossible. And so I have seen so many patients who ultimately don't eat enough protein. And so that definitely can be a pitfall as well. So again, I would say not a hard and fast rule, and you kind of need to figure out what works for you.
Excellent, thank you. Okay, this next question, Dr. Fernandez. How can I learn more about dementia and Parkinson's disease? My family member displays little or no tremors, but cognition has been changing.
Well, the unfortunate reality is that Parkinson patients are at higher risk of developing cognitive impairment and even dementia compared to those who don't have Parkinson's disease. So I think we need to be vigilant as to when it's happening. Being in denial doesn't really help a whole lot because when we're more vigilant, we can intervene a little bit sooner, either with medications or with changing some behaviors, and or maybe even simplifying some of the medications to make it a bit more kind of less confusing to the brain. But you do have a lot of other resources. So, one is your doctor. In our setup, we alternate a little bit with our advanced practice providers, because our nurse practitioners and physician assistants they're very keen on this, and they spend some time in giving some advice and behavioral modification on it. And then, not all cognitive impairment is because of Parkinson's. There are many other reasons why. It could be nutritional, it could be aging, it could be a medication, And so sometimes we do need to get the help of our neuropsychologist to make sure that the cognitive impairment is in keeping with a pattern seen in Parkinson's disease and not something else. And they can also determine the severity of cognitive impairment so that they can give advice on whether the patient really needs to slow down in driving or even stop it, or how much assistance there needs to be done or given to the patient when living at home and things like that. So yeah, I think seeing a Parkinson, having been seen by a Parkinson center, usually they have the resources, the clinical psychologist, like Dr. Rush, who could help with kind of dealing with the consequences of cognitive impairment, the neuropsychologist who could help with a diagnosis and determining the severity of cognitive impairment, the neurologist who can look at medications and simplify it so as not to put fuel to the fire, so to speak. So all of these are kind of play a role into addressing cognitive impairment in Parkinson's. Sure.
All right, so I know my last comment was the routine. So I actually get a lot of people with cognitive issues after the fact. And so with occupational therapy, and actually speech therapy as well, we kind of, at my side, we work together. But that is hence the routine. So I'm gonna look at what you're doing per day, when you take your meds, you know, how is everything going, and try to set up a standard for you guys that works well. And, you know, and then add in some of those cognitive components as well. So, you know, with therapy is a big help with that type of issue. So.
Sorry, I forgot.
Oh, no, that's okay.
Yeah, and I think this gets to a really important issue. If I tie this together with another question that we got online earlier, somebody asked, is it important to see a movement disorders neurologist versus a general neurologist? And of course, we're biased because we are specialized in movement disorders and we have additional training for that. But I think, you know, if you ask what the big difference is, that movement disorders neurologists, other than the experience that we have, we tend to work in a very comprehensive team side by side with other specialists, with occupational therapy, with psychology, with neuropsychologists, physical therapy, exercise programs. And so these kind of comprehensive approaches really come from this kind of teamwork that is a bit different when you have a lot of dedicated energy to really focus on particular problems and populations. And when you comes to issues with advanced Parkinson's disease, particularly cognitive issues and some of the other mobility issues that people have, the comprehensive approach becomes more and more important to being successful. And so that's where we try to thrive. This next question is for Susan. What's the appropriate amount of exercise for somebody with Parkinson's disease?
Thank you. Well, one of the things is exercise is it's kind of based on you guys, okay? So how are you moving, everything like that. But what I recommend is every day. Every day you need to pick something. It doesn't matter, you know, when you look at exercises, you're looking at, you know, a lot of research says, you know, moderate level exercise, but that varies based on you guys, okay? So, you know, we saw everyone doing exercises today. Some people did it in the chair, some people did it standing, you know, multiple times a day if you can. So, you know, say you did 5 minutes, like you were saying, and you picked 5 minutes and that's what you could do, then that's what you can do. And then maybe wait another hour and then do it again. You know, one of the biggest things is not to stay stationary. A body at rest wants to stay at rest. So you really want to keep moving as long as you can, and the best and safest you can.
So, Taylor, this question's for you. How does depression in Parkinson's look different from typical depression?
So, as some of you may realize, when you look at symptoms of depression, a lot of them overlap with symptoms of Parkinson's. So people will have difficulties with sleep. They have difficulty moving and getting around. There's lack of interest and motivation. And so we know that these things happen as a result of Parkinson's and some of the changes that are occurring in the brain. And they also happen in depression. So how do we figure out what's depression versus what is Parkinson's? And I would say that two main things that I look for when I'm evaluating someone and talking to them about their life is, one is irritability. So oftentimes with depression and in Parkinson's, we can see some rapid mood shifts that can occur. People will just, lose their temper more easily, or they're more likely to be short with someone or withdraw from someone, and then be okay for a little bit, and then something happens, and it's just like their stress threshold has gone down some notches, which makes sense. But you see a lot more variability in that in terms of their mood. So irritability is one. And another is social withdrawal, is that people stop interacting as much with the people that they care about, with the events and the activities that they would normally care about. And it's this distancing. And so their world is getting smaller and smaller and smaller. And there are a variety of factors that go into that. But if I had to pick two things that seem to differentiate Parkinson's symptoms that can look like depression versus actual depression, it would be irritable mood and social withdrawal.
All right. So this question we'll pose to Dr. Fernandez, but maybe we'll have Catherine comment on as well if she wants to add. This respondent's asking, my husband acts out his dreams and I end up getting hit or pinched. Is there a medicine to control this? His doctor said melatonin, but that isn't working.
Is it RBD? So I think from the history, it looks like the patient is experiencing RBD, for REM behavior disorder. That means they're acting out their dreams. And that's actually quite common in Parkinson's disease. And we believe the reason is that because Parkinson patients have difficulty fully relaxing. So usually when we're asleep and when we're dreaming, we're super relaxed, super chill. But in Parkinson's, we're a little bit stiff still. And so when we're dreaming, we act out what the dream is, right? And the other interesting thing, it's not absolute, but it's very stereotypical. Women, usually in their dreams, they're running away from an aggressor. And so when they run away, they have a tendency to fall off the bed because they're running away and they didn't know it's in their dream. So that actually is quite dangerous. You could break a bone on that. Men usually are defending their wives or fighting someone. And so they kick or shove or whatever, and they actually hit their wives, usually. So it's an injury. So regardless, the wife is always getting, either they're falling or they're getting hit, right? But it's not always the same. But that's usually what we hear. And so if it's only once in a blue moon, it's a yell, maybe you don't need to do anything about it. The unofficial medication we give is melatonin, which is a hit or miss. The more official medication is a benzodiazepine, kind of controlled substance, a sleeping pill called Klonopin or clonazepam. They just need a low dose, but even a low dose of a controlled substance could be, a bit more significant to some more than others. And so as to when to use it and when to save it is a judgment call as to how bad these RBDs are and how frequent they are. And so it's not very straightforward. Maybe, Catherine, you could expound on that.
Fully agree with everything you said. So, if RBDs there's a wide spectrum, as you said. For some people, it's just every now and when. For some people, it's really can be quite dangerous, right? You can kind of break something if you fall out of bed and so on. So sometimes it can be helpful if this is a difficult problem to treat, to actually see a sleep specialist. I have a few patients where melatonin and clonazepam needed to be combined. And then sometimes what can also happen is that there's a different sleep disorder that might have been undiagnosed. For example, sleep apnea, obstructive sleep apnea, that might complicate things as well. So if it's difficult to treat, we often would recommend a consult with a sleep specialist.
Absolutely. There's a lot of problems in sleep in people with Parkinson's. It could be very complicated. This next question, I think we'll start with Susan on this, and maybe Dr. Fernandez. I do not use Parkinson's medications. Do many people live with PD and not take the medications? I choose exercise to manage and not medications right now.
All right, so choosing to do the exercises, if you want to look at the research, a lot of the research says, again, moderate level exercises. You're looking at normally bounce, they say about 30 minutes if you would prefer not to, but you're doing it several times a day. So, that is a higher dosage with that type of thing. And when you think about moderate, like I said, it's getting your heart going. You want it to be hard to talk. You want not to be able to have a conversation with someone when you're doing those exercises. And, that's what a lot of the research says is, hey, you have to keep moving. You have to move at a high intensity. Even if it's like you're sitting there for a little bit, I will have my clients get up and start jumping a little bit, holding on to something. But I'll have them start to jump up and down just to get everything circulating and then going back to it. So, a lot of my clients, we work really highly with the doctors, with the medications, but they do well with adding those bouts of strenuous or high-level activity in there to kind of decrease some of the symptoms that they're having. So larger amplitudes and, like I said, higher or moderate level intensity. So.
I don't have much to add. Ideally, the more intensive the exercise is, the more aerobic it is, and the more frequent it is, the better. But I'll take anything, anything. The only thing is that it has to be safe, right? Even if you're aggressive, but you fall and have a fracture, that defeats the whole purpose of it. So, as big and intense of an exercise, as frequent as you could do it, in the safest way possible.
And I guess just to add to that, somebody who's just managing Parkinson's with exercise, how do we make that decision then to transition to medications? And then are there other options for somebody that is medication naive with Parkinson's that we might offer them?
Well, at least for at least our group, I could speak for our group, and not just my practice, is that exercise is the most basic thing. Everyone has to do it. Everyone has to move. Now, if that alone is good enough and you're comfortable with it, then we can stay on it, just exercise. Now, at some point, you'll need medications. And so we have to start medications. As to when that is a personal decision. And I view myself as a co-pilot, not the pilot, but the co-pilot. You're the pilot, it's your body, it's your inconvenience or comfort, and so you make the call as to when you want to. But the co-pilot is there for a reason, because if you make the wrong decision, I don't want the two of us to crash, right? So I give the guidelines as to, okay, that's still reasonable. If you want to, sure. But if I think it's harming you more than helping you, then the co-pilot intervenes, right? It's just the same as, hey, I think our flight path here is not right. I think we're going to get in trouble. So it's a partnership, but we're the co-pilot. That's how I see it. And then the situations are different. If you're retired, maybe you have a bit more allowance to wait. But if you're working, maybe we need to intervene a little sooner. It also depends on your occupation. If you're a judge or a priest or a doctor or a teacher or in sales, maybe we need to intervene a little bit more. But if you're working from home and not in a very visible occupation, maybe we could be a bit more conservative. So it's all different. Yeah.
And I think the other thing that comes up is there's a third option if you're just starting to look at different therapies, if you want to be involved in clinical research, and exercise certainly is one of the few things that has some data to show that it may slow the progression of Parkinson's down, but we know it doesn't stop it, and we know it still progresses, and we know exercise is very important, but we are still searching for cures. We're searching for more definitive treatments that may be disease modifying and slow the progression of Parkinson's. And really the best place to find that is when there's not other variables and medications that are treating the symptoms. So we have some options for these folks.
Oh yeah, and thank you for reminding me. So yeah, this is what we do. All our clinical trials, we have 2 alpha-synuclein based medications, and for early Parkinson's disease, untreated, we can potentially stop the spread of alpha-synuclein throughout the brain. It can only be available through clinical trials. If you have the LRRK2 mutation, we can stop also, like minimize or modulate the activity of LRRK2 in your brain cells and the lysosomal function. So we could also do that. The I think SPARX3 had a table. This is the SPARX with an X that is trying to find out whether exercise can actually slow disease progression in Parkinson's. So if you need motivation, well, they're going to put you on task. So that's a good study. And then we have the SPARX with a C, testing an anti-excitotoxicity compound to see if it can slow disease progression as well. So many. Unfortunately, for a lot of these patients, we're looking for Parkinson patients fairly newly diagnosed, not yet on medication, and if they are on a stable dose of a low dose of a medication. So that's the easiest and the best way to determine whether the medication indeed slows progression or not. Yeah.
And so while we're on that topic, here's a complicated question related to alpha-synuclein, since you brought that up. Somebody asked, what body fluids or tissue is used to test for alpha-synuclein? Is it normally present in any amounts? If so, what values?
Well, there are 3 tissues that so far we study, biological product-wise. So one is the CSF, or the spinal fluid. So we poke a very thin and tiny needle in the back to get a sample of spinal fluid, because it's directly related to the brain, and to see this alpha-synuclein levels. We can also spot it in the blood, so that's just an IV intravenous extraction. And we can also spot it in the skin. So it's a skin biopsy. So it depends on the study. And in some studies, all 3, in some just 2 out of the 3, in some just 1. We are trying to develop brain imaging techniques that tag the alpha-synuclein so that we can see how much alpha-synuclein is in the brain without needing to poke people in the skin or in the back or in the veins at some point. No, we're not there yet, but we're getting close.
Okay. This one's for Taylor, and then I'm going to have one back for Dr. Fernandez on shortness of breath after that. Taylor, Doctor, Rush. How can I best manage anxiety during my wearing off time?
So often, as Dr. Fernandez was saying earlier, people can experience wear off from medications up to an hour, or sometimes more before their next dose. And there's some physical changes that are occurring during that can really increase one's anxiety. And over time, as people expect those wear-offs to happen, they get anxious about it because they know it's going to happen. So there's an anticipatory effect to it as well. And so a lot of times when I'm working on how to manage that anxiety with patients, it's trying to keep them as present and kind of mindful as possible in some of those moments when they're otherwise thinking only about their symptoms and how they're worsening and how much longer till I take my meds and how much longer till I feel better. And it becomes this avalanche of very anxious thinking. And so we end up trying to focus the spotlight of attention on other things. How can I focus on other people that are with me? How might I be able to focus on an aspect of my physical sensations that I have some control over? So it may be, for some they can control a little bit more of how they breathe deeply, or they may be able to focus attention on a television program or music that they really enjoy. And so we try to focus the spotlight on something else, because the brain is just that. We don't focus on everything all at once. We focus on things a little at a time. And usually whatever's speaking the loudest is what we pay attention to, which is often those wearing off symptoms. So instead, we're trying to turn the volume knob down on that and be able to focus on other things so that people can get through that period a little bit more smoothly and hopefully a little less anxiously.
This question for Dr. Fernandez. Do Parkinson's medications cause shortness of breath or heavy breathing? What instances we?
Shortness of breath is not very common in Parkinson's. So when they have shortness of breath, I think, who was the speaker who, I think Ellen Walter in her beautiful talk this morning reminded us, not everything is because of Parkinson's disease, right? So shortness of breath is one of those, maybe it's not Parkinson's. It's likely more common to be short of breath when you're having anxiety attacks or panic attacks. You could have shortness of breath. Then that patient goes to Dr. Rush and our psychiatrist maybe. But oftentimes it's a cardiac or a lung issue, and so we want to make sure it's not that. Now, it can also occur in motor fluctuations, in particular with phenomenon we call dyskinesias, when there is this dance-like movements, like Michael J. Fox-like movements. Now, they can also, those dance-like movements can actually, there are two muscles that are underappreciated, skeletal muscles that are underappreciated and can also cause dyskinesias. One, I teach my fellows this when I see it. It's not often I see it, but when I see it, I call them in. I tell them, look at the eyes. They're like moving all over. So the skeletal muscle, the extraocular muscles of the eyes can also be dyskinetic. The other one are the truncal muscles and the diaphragm. They're still skeletal muscles, so they could be wiggling all over the place and could be disrupting normal inspiration and expiration. And they could look like they're short of breath, but they're dyskinetic. So if they're dyskinetic, that's my area. If they're having a behavioral symptom, that's Dr. Rush's area, and our psychiatrist, Dr. Rajaram. But if it's a cardiac or a pulmonary issue, then that's their internists or their primary care doctor's area. So you need to tease out these possibilities.
Yeah, and I know I've seen the same problem in my patient population too. It's not very common. But when we see it, usually we're, as you said, Dr. Fernandez, making sure that there's not a respiratory problem going on, and patients are evaluated by pulmonology or the primary care physician. They get pulmonary function tests, and all that turns back normal. And if we see that there's a pattern to the shortness of breath, that it comes particularly at peak medication cycles, or occasionally actually when they're off too. I've had some patients who have a tightness in their chest, or more of an off-period dystonia where the muscles are just tight, and they don't feel like they can breathe, quite the same way, but their pulmonary function is normal. Then we're probably working on optimizing and smoothing out the Parkinson's medications, so at least we can minimize motor fluctuations and try to improve those kind of difficult symptoms. But it can certainly be challenging, particularly when other possibilities are there that need to be investigated. Here's 1 minute. Okay, we've got a minute. So here's a question about DBS. We addressed this a little bit, but the question is DBS good for patients with gait freezing and shuffling when walking? I would say generally as a category, it's not great for freezing in particular, particularly when freezing occurs in an unpredictable way and when the medications are otherwise working. It can improve the shuffling or slow movements, and particularly that improves with medication. But if there is freezing, even if the freezing is more predictable, that sometimes becomes less predictable over time and becomes a very challenging treatment or a challenging symptom to treat with DBS. And then the last thing here is there's a few questions, and we got this online as well. Will these presentations be available? And yes, so after today, you should get, I believe, an email with a link to all the recorded content from today's sessions, and you'll be able to go online and view any of the presentations as many times as you like for a couple months, and then I think it'll probably be moved over to one of the Cleveland Clinic websites to archive. So we will have these videos available in the future if you want to look back at them, and I think you can probably look at previous years as well. And yes. And also for our care partner, Empower You as well.
All right, so thank you very much to our panelists. And thank you again to everyone for joining us today. We hope you have learned more about Parkinson's disease and will leave today feeling better equipped with more strategies for living well with it. Thank you again to our sponsors and volunteers. Please remember to turn in your surveys to collect your t-shirt, and we hope to see you again next year.